Got your own too.
Dr. Low, who is the chair of cardiology here at UC Davis. One of the biggest compliments any physician can get is that other physicians want them to take care of them. And I think Dr. Low sees more physicians for their cardiovascular needs than anyone else. He is a world-renowned interventional cardiologist, and it's really an honor to introduce Dr. Low. Thank you for being here, sir.
Dr. Siddiqui, thank you very much for the kind introduction and the invitation to be part of this very impressive program. Unlike the previous presentations, my presentation, instead of being very high-tech, is very low-tech. I've been interested in device development for the past 10 years, and I thought I would show you our latest effort at trying to fix heart valves without surgery. And in the interest of time, I've actually decided to omit the second half because it just isn't enough time to go through it well. These are my disclosures. We get fellowship support from a lot of these different companies. Anyway, healthcare is going through a lot of changes, and essentially what we're trying to do is to put the surgeons and anesthesiologists out of business. And that's how you make money. And these companies are usually started by engineers anyway. They're the smartest guys on campus. And so they start these companies for a few $1 million, and then they get more funding after they prove the concept. And then they sell it for somewhere between $100 and $1 billion, $100 million and $1 billion. And then they retire or they start another company. But basically, things like gallstones, lung masses, holes in the heart, coronary disease, and so forth and so on, we've been able to take care of with less and less invasive technology. We do laparoscopic things now. We use devices to close holes in hearts without surgery. We put in stents instead of bypass surgery. And so we're now trying to figure out a way to replace heart valves or to fix them without surgery. So the condition that I'm going to address today is aortic stenosis. And aortic stenosis is a condition where this heart valve called the aortic valve, which is the last valve between the heart itself and the aorta when the blood comes out, it's normally about the size of a quarter, and it has 3 leaflets that are very pliable and can open completely, and this hole should open to the size of about a quarter. There are different conditions where these valve leaflets become thickened and they get stuck together and they don't move very well, and the hole then becomes very small. And when this hole usually gets somewhere below a centimeter square, patients become very symptomatic and they need to have it fixed, and there's no good way to fix it without surgery. So this is the natural history of the disease, and there's a very long latent period. They do very well, but once they have the onset of symptoms with either chest pain, passing out, or congestive heart failure, these patients are at high risk for dying over the next couple of years. So once patients become symptomatic, something has to be done. So the standard of care is, of course, heart valve replacement. So in that scenario, the patient goes to the operating room, they slice open the chest, they split the breastbone open, they put you on heart-lung bypass, and then they take out the old valve, sew in an artificial valve, either a mechanical valve or a tissue valve, sew you back together, and the surgical risk is around 3 to 6%, and when you combine that with bypass surgery, it goes up to about 7%. But there are a large number of patients that are such high risk for dying or having a major complication at surgery that it's really not feasible, and they're turned down by multiple surgeons. So I thought I'd just kind of show you what's out there at the present time in terms of how we're dealing with this. We make the diagnosis by listening to the patient and physical diagnosis, but the gold standard now is really echocardiography, using sound waves to image the heart and also Doppler to look at the hemodynamic parameters. And the heart valve is here, the aortic valve. This is the mitral valve. This is the left ventricle. The aorta is out here. This valve doesn't move very well, and in cross-section it's shown here. And you can see that it just doesn't open well, and by Doppler, of course, there's a big velocity and suggesting that there's a very small hole there. So we need to somehow fix this without surgery. Now, this is a few pictures from our new 3D echo machine, which we just got about a month ago. And this allows us to put a scope in the esophagus and to image this valve very well, and we can do 3D reconstruction on the fly, and we can look at it in 2 planes, and it's very impressive technology. Now, if you take different kinds of patients, you can see that the risk can be less than 1% for dying in a 55-year-old with bad aortic stenosis and no other medical problems, going to over 25% risk for dying in an 80-year-old that has a bad heart valve that had previous surgery and kidney dysfunction. So it's very important that we understand the natural history of the disease as well as the operative risk for a patient, because in the end, what we want is a good outcome for that patient. So there are different kinds of scoring systems that help us predict a patient's risk for dying. So if the risk is over 20%, it's felt to be, in some cases, not an adequately acceptable risk, and so we need an alternative, and that alternative is to do it without surgery. And so we have now developed a number of percutaneous aortic valves. Now, these valves should work very well. In other words, their function should be good. They need to have a large effective orifice area that's similar to what they had before the valve became diseased. Additionally, the valve should be very durable that they put in and last more than 10 years. It should seal very well in this position. It should stay in place and not embolize, and it can't interfere with the coronary ostia. In order to deliver it, it has to be low profile so we can get it through the blood vessel system. It needs to be flexible and trackable. We need to be able to position it well. And if it's not positioned well, we need to be able to reposition it and retrieve it. The first generation devices were introduced in 2002, and this is a heart valve that's made in a stent. So we've had stents for a long time, but this is a very large stent, 23 millimeters in diameter, and now they have a 26 millimeter diameter stent. And they initially used equine pericardium to create this valve because it was thinner and they could make the valve smaller and lower profile. But they now have been able to use the standard bovine pericardium to create this valve because it has better longevity. So the valve comes in a little jar, and then before we put it in, we crimp it on a balloon catheter like this, and it's balloon mounted. And then that valve is put in retrograde around the aorta across the valve that's been stretched open with balloon valvuloplasty, and then the device is deployed in place. And of course, because the heart's continuing the pump and they're not on heart-lung bypass, you have to do it very quickly. This here on the left shows that the pressure inside the heart with aortic stenosis is very high, but the pressure that's measured in the arm, or the normal blood pressure, is markedly reduced. And this gradient is the sign of significant aortic stenosis. And after the valve is implanted, you can see that the pressure that's measured in the arm is the same as the pressure that's inside the heart. So it's a complex procedure, but it's an alternative to patients that are too sick for the standard kind of aortic valve replacement. So this is how it's done. Here's a wire across the valve that's been stretched open, and with rapid pacing we deploy the valve. And the reason we have to pace the heart at over 200 beats a minute is because the heart is continuing to eject, and at normal heart rates of about 70, this balloon, when it's inflated in that position, will want to be ejected. So by pacing the heart at 220, the heart's really not pumping very much blood, and we can deploy it in exactly the right place. So after the valve is put in, we check it, and we inject dye, and we can see the valve in place, and it doesn't block the coronary arteries, but you do see some dye going back into the left ventricle. And so this is a paravalvular leak, and it's generally minimal, but it can be substantial, and it can create another problem for the patient, which he didn't have before. So this is not an ideal solution, but it does work for many, many patients. So in the different trials, the anticipated 30-day risk was about 30%. death at 30 days, and the observed mortality was in the 10-15% range, except for this one trial where it was 25%, but all substantially lower than the predicted risk. So this does appear to offer a reasonable alternative to those patients that are too sick for surgery. Now, the device has been studied for many years, the first one being implanted in 2002. They achieved CE mark, which is the European approval, in 2008, and at the present time, about 100 implants are being done monthly in Europe by Edwards Life Sciences, based in Irvine, California. There are about 1,200 implants to date, and each of these sell for $30,000. So it's not trivial amounts of money. It's a big amount of money, which is what drives the development of these new devices. The next goal, of course, is to miniaturize the device so it'll be a lot smaller, and of course they're going to use better materials to make that smaller. Now, there are some patients that have bad peripheral vascular disease that still need that valve, but they can't put it in through the iliofemoral system in the leg. So what they do in these patients is they make a little cut down over the tip of the heart, the apex of the heart, and then they put it in retrograde through the heart with the heart still beating. They put a purse string suture through there, and this valve can then be deployed directly from the left ventricle across the aortic valve, and again they do this with rapid pacing. So this is an alternative to those patients that have severe peripheral vascular disease. There's another company based out of San Diego that has a similar percutaneous valve. That company is called CoreValve. The difference in their valve is they use a very long stent, and this is a self-expanding stent made out of nitinol with different strengths. The higher part is bigger, the middle part is smaller and is away from the coronary ostia, and the lower part has a lot of radial force to keep it in place for securement. And this also has CE mark approval, and again, they're doing about 80 to 100 a month in Europe at the present time, again selling for about the same amount of money, 20,000 euro or $30,000. So let me just then finish up by talking about our effort. DirectLow is a company out of Santa Rosa, and we've done virtually all of their development work here in town in a small animal lab. And what they've developed is a heart valve that, instead of using a stent, has a structure that supports the tissue that's made out of a balloon and fabric. And you can inflate these different rings through these connectors, and you can inflate one ring at a time. And these connectors have check valves, so you can disconnect it at the end, and this is what it looks like in real life. So it really has no stent. It has a support structure that's made out of balloon and fabric. It's covered with Dacron so that it can endothelialize. And we initially fill it with contrast, half saline and half contrast. And then if it's in place and functioning well, we can then replace that material with water-soluble epoxy, and it hardens over 90 minutes and keeps it in place. It comes at the present time in two sizes. We can deflate it and take it out, and we can reposition it as well. And it's been tested for over 200 million cycles in a tester. It has a good delivery system that's very flexible and trackable. The housing itself is 22 French. The shaft size is 15 French. And this is what it looks like when it's loaded into the housing. There, it's unsleeved in the left ventricle. This is what it looks like when it's inflated. If it doesn't look like it's going to work, we deflate it, and we can pull it into a little basket and take it out of the patient. So this is a movie of one of our first implants done over in Hamburg. And this is a CT scan showing how we sized the thing and look at the ascending aorta, the coronary ostia, as well as the valve itself, the left ventricular outflow tract. So it's done in a cardiac cath lab, but the patient is put to sleep at the present time. And a cut down is done in the femoral artery area so that we can achieve access, because the sheath itself is 22 French, so it's about 7 millimeters in diameter. So it's a big tube at the present time that should be smaller in the not too distant future. So that tube is put in over a guide wire into the descending aorta, and the whole time we're doing the procedure, we're monitoring the heart, and especially the heart valve with echo Doppler put in through the mouth and into the esophagus. So we're looking at the heart valve here, and here we're planimetering the valve area to prove that, in fact, it is a very small outlet. and that there's a very high gradient across that valve. So after that's been done, we put a catheter in to take a picture of the ascending aorta and heart valve to look at the size of the aorta, as well as to confirm the position of the aortic valve annulus, and then look at the coronary ostial takeoff. And you can see that the leaflets barely move. So then the cut down is done, the sheath is put in, and the first thing we do is we put a balloon in the left ventricle across the aortic valve, and we blow up that balloon to stretch the valve and make it very pliable. Because it wouldn't open before, we can take a balloon and stretch it open. If we leave it after the balloon, without putting a valve in, it'll close off in the next 3 months or so. So it's not durable, which is why we have to have a valve put in after the balloon valvuloplasty. So here's one of our engineers who's preparing the valve. He takes it out of the jar and he loads it into the delivery system. And you can see the valve. It's made out of bovine pericardium. It has the special treatment that's anti-calcification, just like the regular surgical valves that are implanted. Okay, and these are the support structures. Here it's loaded into the housing because it comes prepped in glutaraldehyde, so it has to be washed and then loaded. So once we've done that, we've got a stiff wire across the heart valve, and we put the valve into the left ventricle, and we blow up the bottom ring. That bottom ring is very precisely sized so that it pulls up against the annulus of the heart valve itself, and then we can take up the upper ring to hold the leaflet against the wall. And this is all done with saline and contrast. So here it's being advanced through the iliofemoral system over a very stiff guide wire, and we watch this under X-ray control, and you can see that it does track around the aortic arch and across the valve into the left ventricle quite easily. So once it's in there, we then unsleeve the device and pull the sheath out, and then we blow up the bottom ring, and using these 3 different little tubes, we can position it and pull it up against the aortic valve annulus. Remember, the valve is already functioning once the balloon is, the lower ring is inflated, so there's nothing pushing the valve out. We have to pull it up against the outflow tract. So once the echo tells us that it's in good position, we can then inflate the upper ring and then secure the old valve in the middle here, trapped between the upper and lower rings, and we can look at the pressure gradient, which was over 100, and it's now reduced to about 10. You can see there's the pressure difference. Okay, it's not quite 0, it's about 10, but that's not physiologically important. If we don't like the device, we can deflate it and withdraw it and retrieve it into the basket. So this is a next generation device because the previous stented ones cannot be repositioned nor withdrawn. So this device allows you to take your time, make sure that it's in good position. If you don't like it, you can take it out. So once it's in position and we like it, we can do an aortogram, make sure that it clears the coronary osseous so there's still good blood flow down the arteries. And then we can disconnect those tubes after we fill the lumen of the balloons with epoxy contrast. So when it looks good and we check it by echo as well as the physiologic hemodynamic measurements, we can then exchange the contrast media for the epoxy media. This is the scope that helps us monitor it. So once we put the epoxy in, then we can disconnect the polyamide tubing and withdraw it, and the valve is left in place. The epoxy is mixed over 30 seconds. It's put into a hoop that dissipates the heat of the reaction, and then it's put in through these polyamide tubing, and once it's in place, we then can unscrew these tubes from the valve itself, and you can see that in a second here this will release. There, the first tube is released there. So we release all 3 tubes, and then it's left in place, and it hardens over about a 90-minute period, and then we put in our percutaneous valve without heart surgery. So where are we now? I think it's a very reasonable alternative at the present time for patients that have inoperable disease or have such high morbidity and mortality risk that it's not feasible for them to have surgery. We don't know how long they're going to last. We hope that they're going to last 10 years or more. Deliverability for some of the devices remains an issue. Many of them still have perivalvular leak as a problem, and these devices have to be relatively strong to hold the old valve in place. So it's clearly been demonstrated in multiple studies now that it's feasible and safe, and it's gained approval outside the U.S., and we are doing a trial in the U.S. now, and I would anticipate in 2.5 to 3 years we'll have those percutaneous devices here. The next generation devices, and the DirectLow is one of them, will be retrievable and repositionable, and after these things wear out, it's also good that they can have surgical replacement of the percutaneous valve should that ever go bad as well. So what are the opportunities in cardiology that I see? Well, I don't think there's much opportunity except maybe for a bioabsorbable drug-coated coronary stent, because there's so many companies and there's so much money already working on this that it would be hard to make a better mousetrap than what's already being developed. But clearly there is no device that treats tricuspid regurgitation very well, and this is a definite opportunity. There are lots and lots of patients with tricuspid regurg that could be repaired or replaced non-surgically. Congestive heart failure is probably the #1 problem in cardiology, with poor treatment modalities other than cardiac transplantation. It's that the heart muscle itself is very weak, and if you can devise some kind of mechanical assist that's not a pump to help the weak muscle pump better, that clearly will be a major breakthrough. The mitral valve, there's nobody that I know that has a percutaneous mitral valve, because the mitral valve annulus is a difficult structure to secure a valve to, and there's a lot of force pushing the valve back into the left atrium with each systole. But if you can make a good percutaneous valve, this is a huge market as well. And as Dr. Laird talked about, despite the fact that there are a number of chronic total occlusion devices, there is no good one. And if you could find a good chronic total occlusion device, this would make life very, very difficult for our coronary bypass surgeons. So with that, I'd like to end the presentation. Thank you very much.
Thank you very much, Dr. Low. If